This is Amy Gibson, Chief Operating Officer with the Patient-Centered Primary Care Collaborative. We'd like to welcome you today to our monthly webinar that's part of our series in helping patients and families become engaged with clinical transformation as part of our funding through the Transforming Clinical Practices Initiative from CMS. Our Support and Alignment Network is working not only with clinicians that are officially enrolled in TCPI and all of those efforts, but across the country, we're trying to work with and encourage and provide support to patients and families who are partnering with clinicians in really trying to change the way we deliver care in a way that improves overall health, reduces costs, and really engages all clinicians and patients in a team-based model of care that supports ongoing improved health of the population. We're really excited today to have one of our key partners in our SANG grant with us today is Sarah Guastello from Planetree. She's the Director of Knowledge Management, and Dr. Dale Waxman, who's with the Carolinas Healthcare System. You're going to get some incredibly valuable information from them today on the role of leadership in creating a culture of patient and family-centered care. As many of you know, this is a key element, absolutely critical to have leadership actively engaged and committed to changing the way care is delivered in a way that creates this overall culture of patient and family-centered care. And you're going to get some great information from both Sarah and Dale today on how to make that happen. Of course, we'll have this webinar broadcast archived up on our website by the end of the day tomorrow. So for those of you who are not able to participate in this live presentation, you'll have access to the slides as well as a recording of everything by the end of the day tomorrow. So I would encourage you and those of you who are on the call, but your colleagues can't participate, to please go and access that information. It'll be available into perpetuity, so no rush to get there. It's going to be incorporated as part of our national curriculum in really helping to support all of these activities in patient and family engagement and quality improvement. Today, for those of you who are with us live, you'll have an opportunity to ask questions of our presenters. We don't do an audio raise your hand kind of questioning, but we allow you to type your questions into the chat box. So you should see that on your dashboard. At any time during the presentation, please go ahead and put up your questions. And then at the end of the presentation today, I'll be asking those questions of our presenters. Because we've had such great participation from all of you on these webinars, we've extended the length of time for those of you who want to stick around if there's still more questions that we haven't been able to get to by the end of the hour. So for those of you who do need to go, we totally get it. We've got lots of busy lives and things going on. So if you need to sign off at the end of the hour, that's fine. Again, we'll have a recording of all the questions up on the website afterwards. But for those of you who would like to stay and engage a little bit longer time with our presenters, then we've given ourselves a little bit of a cushion to respond to those during those office hours. So I'd encourage you to stay if you're able to. That's all the information I think I have from my end. So with no more of my chit-chatting away, Sarah, I'm going to kick it over to you to start the presentation for us.
Great. Thank you so much, Amy. I'm really pleased to be here, and I will tell you a little bit more about Planetree in a moment, but suffice it to say that Planetree is really proud to be a part of the Patient Caregiver and Community Engagement Support and Alignment Network, and to be working alongside PCPCC and the IFPCC and YMCA on this really important work. So today's webinar is going to focus on something that may seem slightly tangential to the content of the other webinars in this series, but in fact, engaged and committed leadership is really not tangential at all to this work. It's pivotal to setting the groundwork for a practice to effectively engage with patients, family members, and community partners. So I think in general that statement about the importance of leadership is fairly widely accepted, and if we were not on a webinar and this was in person, I imagine there'd be a lot of nodding of agreement that yes, leadership is pivotal, but acknowledging the importance of leadership and acting on that knowledge are certainly two different things. So we'll spend the next 30 to 35 minutes or so walking through some very specific leadership principles that convert that concept of engaged and committed leadership into something that feels more concrete and more actionable for you. And then, because sometimes even that can still feel a little murky, I'm going to turn it over to my co-presenter, Dr. Dale Waxman, to share some examples of how these principles apply in real life. And just a little bit more about Dr. Waxman. He is the interim chair of the Department of Family Medicine at the Carolinas Healthcare System in North Carolina. And that department includes a practice with a long-standing commitment to building a culture of patient and family-centered care. So today, he's going to be really drawing on his experiences as a leader in that department and in that practice to illustrate these patient-centered leadership principles in action. So I think this quote is a good place for us to start this discussion as we sort of reflect on what brings all of us here together today. This notion of patient and family-centered care has indisputably become really part and parcel of mainstream thinking about how healthcare should be delivered and operate. And that certainly was not always the case. But today, adopting patient and family-centered principles and practices and structures is no longer something that only the most progressive or enlightened healthcare organizations are doing. It's definitely recognized as a driver for how to deliver high quality and high value care. And for Planetree, the organization that I'm representing today, that's so immensely gratifying. Planetree is a not-for-profit patient-centered care education, advocacy, and coaching organization, and we've been promoting the concepts of person-centered care since the late 1970s. And certainly back then, most of the ideas that these early patient-centered care pioneers were advocating for were considered really radical. But that's definitely not the case anymore. Today, Planetree works with more than 700 healthcare sites across the full continuum of care in 19 different countries. And what's particularly relevant about Planetree as it pertains to today's discussion is that our emphasis is largely on how organizational cultures can be enhanced to really fortify patient-centered practice and structures to be sustained for the long term. And leadership is most certainly at the top of that list of those key cultural elements. So you only need to look at this slide if you had any doubts that patient and family-centered care is an idea whose time has come. This is certainly what going mainstream looks like. Patient-centered care concepts, as you all know, have been embedded into policy initiatives and research agendas and reimbursement models. And because of this, it's on the radar screen, or perhaps more to the point, it's embedded into strategic and operational plans of a critical mass of healthcare providers today. So certainly the will is there to achieve a more patient and family-centered healthcare system, and that will is really stronger than ever before. So then we want to look for the way, right? And that's what the TCPI change package really provides. It's that roadmap for implementation. And just to sort of connect the dots here, where we're going to be focusing today is on driver 2.1, engaged and committed leadership. And the change ideas in that change package provide some great direction for moving forward. But I think it's important to acknowledge that transforming a practice requires more than implementing some of these well-established change ideas. And that's because ultimately, transformation is not just about changing what we do, but really how we do it. And to go one step further, it's about sort of the connection that everyone on the team feels to the work and to that shared understanding of the reasons and the value behind the effort. Based on Planetree's experience, practices that are successful in creating this new culture are led by leaders who understand then how to move their teams in the same direction while really motivating them to reach beyond what's familiar, reach beyond what feels comfortable, and to reach beyond sort of the current status quo. The flip side of that would be leaders who are more focused on documentation and practices and processes as a means of checking the boxes necessary to be eligible for better reimbursement rates or to achieve recognition. And that's sort of sending the wrong message to teams. And it's going to fail in the long term to build the kind of really strong and robust culture that's key to enduring change. So that's a fairly basic and simple premise or series of premises to build off of, but I don't want to suggest that just because it's a simple premise that what we're going to be talking about is easy to do. I think we have to acknowledge that it's not easy to do. What I've just laid out is a really challenging proposition for a lot of leaders. And that's because I'm sure that in every one of your practices, and really in our healthcare system at a more macro level as well, things have evolved to occur in a certain way for good reasons. I mean, the way that we've been practicing for many, many years is not arbitrary. There have been really good and sound reasons that have led to those processes and practices. And now we're being challenged to re-engineer those processes and practices, also for very, very good reasons. And because of that, and because we're all human beings and it's human nature, there's some very natural clinging to what we've known and how we've operated. And it's not uncommon that there's going to be resistance, both from leaders and from the teams, to make some of these changes and to really venture out into that area that doesn't feel as comfortable and doesn't feel as familiar. And that combines to make this work far from easy, even though the premise itself may be fairly simple. So what I'm hoping is that you'll come away from today's webinar and from what Dale and I share really energized that though the work may not be easy, that it's very much worth doing. So one thing that makes it more feasible is breaking down that large abstract concept of engaged, committed leadership into a simplified framework, and that's what I've laid out for you here. So drawing on Planetree's experience of patient-centered culture change, we've identified these 4 critical leadership factors for creating a culture of patient and family-centered care. And we'll go through each of them one by one, starting with create a shared vision, which aligns directly with the TCPI change package. So in each of your teams, you have different folks with distinct roles, and everyone likely knows their job. And they are very familiar with the tasks that they need to do each day. But the bigger question is, does everyone on the team understand how each of those tasks is connected to the greater purpose or mission or vision of the practice? And it's the role of leadership to share the vision in such a way that it becomes not only meaningful, but ultimately energizing and inspiring for all members of the team in order to ultimately transform those day-to-day routine tasks, or how those day-to-day routine tasks are perceived, into a deeper understanding of how they're all essential elements to living out that vision. But when we talk about creating a shared vision and communicating a shared vision, it's more than posters and screensavers that tout things like putting patients first and respecting others, pursuing excellence and doing the right things, all of which are great and noble aims. And it is really, it's a very good idea to give public visibility to the shared vision. It keeps it top of mind for all team members, which is important, and it can also create greater accountability and set certain expectations for patients and families when it's shared not only among sort of the care team members, but more publicly and in public areas within the practice. But really engaging the hearts and minds of team members is going to require more than those posters and screensavers and email blasts. And I'll share with you some ideas or examples of what I mean by that. At Planetree, we coach leaders to adopt a more experiential approach to help all members of the team really internalize the vision and understand it at a deeply personal level so they can embody it and really live it in the real world. So Doing things like starting every staff meeting or huddle with a patient story can help to center everyone on what matters most about the day to come. Or having a staff lunch and inviting everyone to share with each other why they chose a career in healthcare in the first place. That can be a really powerful way of demonstrating this commonality among every member of the care team, even though folks are in different roles and came to this work from different paths. Sort of creates that common ground for everyone. You see here some images of some team members engaged in a team building exercise. Again, just sort of taking them outside of the normal routine to think about things differently, to work together in a slightly different way. Down in the lower right-hand corner, you see commitment cards. These were done by a number of healthcare workers in a hospital where they actually wrote down something they personally were committing to do to advance the organization's patient and family-centered culture. And those were then posted and shared. Again, the idea being to really personalize and internalize what it means to deliver patient and family-centered care. We've also recommended inviting staff to do office walking rounds and having them intentionally adopt the perspective of a patient. That can be an effective way to resensitize teams to what it's like for patients to come to the office versus the experience of staff who come in and day out and may not view the office and the environment through the same lens as patients. So certainly don't take the place of having patients come in and do a similar type exercise, but it's again just to help promote that perspective taking, looking at processes and the environment and systems through the lens of the patient point of view. And really the function of all these types of exercises is to address the fact that too often in practices, daily tasks overwhelm purpose. And the to-dos of the day can overshadow the meaning, the profoundly important meaning of the work that's being done within the practice. So participating in these kinds of experiential patient-centered care immersion exercises can really fortify that sense of purpose, that we're all in this together and the work we're all doing matters. And these types of activities create the seeds of change in a way that changing policies and workflow don't, because it really personalizes the effort. It engages the hearts and minds of all members of the care team and can help the entire team to remain focused on what matters most, even on the most trying of days. And it can restore a sense of purpose and joy to the profession, which, as we know, is so critically important. So that's the great sort of intrinsic value to doing this type of work, connecting to purpose. But the experience of Planetree sites, this is a hospital that began implementing patient-centered care retreats for all staff back in 2003. It demonstrates that connecting all staff to a shared sense of purpose can also have a very significant impact on patient and staff satisfaction as well. I don't need to say too much about this because I think the data really speaks for itself. So moving through the framework, we'll move to modeling organizational values. And nothing takes the wind out of the sails of a practice transformation effort more than leadership who adopts the mentality of do as I say and not as I do. And I don't think that that's ever an active choice, but it does happen, and often it happens subconsciously. And so it does need to be a very active and conscious effort on the part of leaders to ensure that their behaviors and attitudes are consistently aligned with the organization's core values. So that means listening. It means really listening. In fact, one suggestion would be sort of adopting that teach back methodology that we use with patients, with team members as well, and making sure that as a leader, you're on the same page and understanding when team members come to you with a question or a challenge or a concern that they have, that you're sort of teaching back to them and conveying a common understanding of what they're coming to you with. It means providing feedback in constructive ways. It means saying thank you and being specific about it, meaning it. So rather than sort of global, everyone's doing a great job, I know it's been some, we've been going through some challenging times, really identifying specific behaviors or actions on the part of individuals and recognizing them for those activities. Participating and rolling up your sleeves, so doing what needs to be done. And maintaining a visible presence. So for some of you in small offices, there's really no other option, right, but remaining visible. But if you're part of a larger system, it may be that teams in offices rarely see the leaders who are responsible for guiding the change effort. So making an intentional effort to rectify that and to connect with staff in the offices provides reassurance to those teams that decisions being made at the highest levels really are grounded in a true understanding of what's happening on the front lines. And the flip side of that is transparency. And when you adopt sort of a transparent approach around decision making, it gives the entire team insight into how decisions are made and priority setting. So I've provided a handout that's available to all of you sort of in the dashboard called Patient-Centered Leadership Self-Reflection. It's a little different than any other sort of leadership self-assessment you may take. This is more something that leaders are encouraged to, it's a series of 12 questions, and it just sort of prompts you to consider how satisfied you are with certain aspects of how you feel you've led over the course of the past 30 days or 60 days or whatever the time period is. And you're encouraged to take it on a regular basis to kind of hone in on where do you want to focus a little bit more, or also to recognize and pat yourself on the back for the areas where you've really been doing a great job. So I do want to confirm I have control of the slides. I know I lost control for a minute there.
It looks like you do, Sarah.
Okay.
Just try clicking in there again.
Okay. The third area of the leadership framework is recognizing knowledge and decision making. And as important as engaged leadership is in practice transformation efforts, leaders alone do not transform practices. That would be a great fallacy to think that was the case. This is an all-in endeavor, and it's not going to succeed without the active engagement of staff and patients and families and community partnerships. So a patient-centered leadership model provides clear direction that includes the patient voice and the employee voice in many decisions. And this is a new frontier for a lot of leaders. And it can be one that feels quite risky, but it's also one that can provide the most growth and overall satisfaction and results. So when we talk about recognizing knowledge and decision making, essentially we're talking about inclusion. And I think that that's a term that can be pretty daunting for some leaders, maybe even a little distasteful at times to think about inclusion. Maybe you're concerned or fearful that inclusion will essentially become a platform for everyone with a complaint to just continue to bring that complaint to the forefront. You may be concerned that it'll end up becoming really distracting and that inclusion will end up distracting you from the practice's most pressing priorities. So I think it's really important to demystify what inclusion really looks like. And we'll start by talking about what inclusion is not. And inclusion is not everyone being involved in everything all the time. And it's not used for every decision in the organization. However, what it does mean is that leaders recognize that their perspective alone is not sufficient for informing some key decisions within the practice around specifically the patient experience, as well as the staff experience. And so that there is a very intentional process put in place for gathering feedback and opinions and input from those that come from very different perspectives and are viewing these questions through different lenses. And even having said that, perhaps you share some viewpoints with the physician who's quoted here on the slide, who said that he came into this process of partnering with patients and family members with a great deal of skepticism. He wasn't really sure what they were going to bring to discussions, and he was concerned that the learning curve of patients and family members would be too steep to really result in any sort of meaningful involvement. He also had some concerns that if patients and family members were in the room or were part of these discussions, that the conversations wouldn't be as candid or perhaps as constructive. But his experience of actually doing this and inviting patients and family members to be a part of the improvement work demonstrated to him that his fears were unfounded. And what he found, in fact, was that patients brought tremendous value to the discussions, and having them involved, as he says, ensured the group that they were moving in the right direction. And I find that so astonishing, because what it suggests is that prior to involving patients and family members, this group was moving ahead hoping that they were moving in the right direction, but a little uncertain. And that seemed reasonable. But now that he's sort of on this path, and this group is on this path of engaging patients and family members in these new ways and in these discussions, he recognizes that it's no longer reasonable, that it actually is helping them and enabling them to get to the right patient and family-centered solutions in a more accelerated manner, because patients are helping to guide them there. So in terms of leadership's role, that means as a leader engaged and committed to this work, it's up to you to accept these risks and to be a little vulnerable and to acknowledge that patient and family-centered practice transformation is not going to occur in the absence of this type of partnership with patients and family members. And so it's really vital to put in place structures and systems to harness those perspectives. And these are just a few examples, and obviously in this webinar series, it's something that we've been exploring in depth. And Dale in a moment is going to share some specific examples of how his practice did just this and the impact. So we'll get to him in just a couple minutes, but I want to finish up by talking about this fourth aspect of the framework for patient and family-centered leadership, and that's cohesion between principles and practices. Because ultimately, we're talking about the maintenance and nurturing of a culture. And so to echo an earlier point, this is bringing that cohesion between what you do and how you do it. And how we do it needs to be not for patients, but with them. And when we do that, the lens through which we're considering the patient's journey really changes. And as a result, how we prioritize what matters most shifts to be more reflective of the patient's perspective, and really exhibiting caring attitudes and inclusion and embracing family as integral members of the care team, and making sure that patient preferences are incorporated into care plans, and conversations about patient preferences are understood as a vital part of sort of getting to know patients, and that's vital patient information that we need to be capturing and disseminating among the care team. And all of that is what ultimately creates a patient and family-centered experience for individual patients, and ultimately a patient and family-centered culture for the practice. So with that background essentially on the leadership framework. I'm going to turn it over to Dr. Waxman, who has been, as I said, traveling this road of patient and family-centered care for some time now, and he's going to share with you some real-life examples of how these principles have manifested themselves in the culture of his practice and the results that the practice has seen.
Thank you very much, Sarah. This is Dale Waxman. I'm very honored to be in this discussion today, so thank you very much for the opportunity to share some of our journey here. Just to give some context, I am in a very large healthcare system based in Charlotte, North Carolina, but is over both South and North Carolina, a little bit of Virginia, a little bit of Georgia. There are over 40 facilities, and I'm in the academic wing of the organization and an interim chair of a department of family medicine. And we have a practice that is right adjacent to a community hospital that is one of the partner hospitals that has also gone through the patient-centered journey over the last 8 to 9 years through Planetree. So I'm in academic family medicine, and we have a family medicine practice that I lead as well. So what I thought I would do is to just go through some examples of what my team has done to facilitate the patient and family-centered culture by going through these 4 components and giving examples of what we have done so that we can make a little bit more concrete, which Sarah has just shared with you. So I'm going to go through each of these bullet points one by one and give some examples of what we have done as well. So to begin with, in the creating a shared vision, one of the pieces that Sarah had shared a few moments ago was the idea of a patient story to create a context by which we are actually doing the work that we're doing. My first bullet point is that we just have appointed a new CEO of our entire healthcare system, just started a few weeks ago. And what we heard very early on, I think it was day 2, was that he really appreciated that each meeting begin with a connect to purpose type of story. So there it is right there. The leadership of our entire organization is very much invested in this concept of what are we doing here? And let's each moment that we are meeting together reflect on why are we here in the first place before we get into the nuts and bolts of how we do things. Now, prior to him coming here, and perhaps this is why he chose to come here, several of the parts of our organization were doing this already at the beginning of meetings to sort of say, what is the purpose of doing this? So in my faculty meetings and in our practice meetings, we actually start our weekly meeting with a story, or it could either be a story that a patient shared by writing to the practice manager about the care that they received, or something that somebody heard. One of our other purposes in academics is to train patient and family-centered residents and medical students. So we also will reflect on stories about some of our learners who have graduated and reflect back to us what they learned. And so our purpose is creating good family physicians as well. My second bullet point is just to echo what Sarah said earlier, is that a lot of our processes can cloud the purpose. And increasingly, we're seeing more and more of that. I'm sure we're not unique. We just this last week started physician order entry in our electronic health record, which is another distraction from becoming patient and family-centered. The other piece that we're constantly after is improving our quality metrics. And one of our current focuses is on colon cancer prevention screening. So, and all team members in our practice are involved in helping patients to get their colon cancer screening in one form or another. And we actually spend time a couple times a week looking at a few quality metrics, one of which is colon cancer screening. And we've broken down the different steps in workflow that we could make different to improve our rate at getting patients screened. And every once in a while we get so bogged down in the details of who's doing what that it stands to reason that we stop and pause and go, why are we doing this in the first place? And so I actually noticed one of those moments a few weeks ago when we really were getting bogged down into who's doing what, who's making sure we get the colon cancer screening, hemocult cards, who is making sure that they get the referrals. And a lot of people feeling that I'm getting burdened by doing more of this stuff, and they may not know that their actions actually improve lives. And so I paused and I asked people to just reflect for a moment that what we're about here is preventing morbidity and mortality from a very common cancer that occurs in the United States, that if we catch it early has a very significant impact on patients' lives. And to just pause and reflect on that, that's why we're doing what we're doing. The next step is the modeling organizational values. So one of our organizational values in my department is that we want to be not problem-focused, but to be solution-focused. So we'll rapidly shift our thinking around problems into how do we see this as an opportunity? What do we need to do to, what are the things that we need to do to make this, to be living more in the solution and less embedded into what is going on in terms of the problem. Our organizational value is to be collaborative in our decision making, and as Sarah pointed out a little bit earlier, it's not about everything has to be consensus, but that is our first go-to place is let's get everybody's perspective. We're going to make these decisions collaboratively. We've really flattened the hierarchy in our department, and in family medicine in general tends to be like that anyway. And so we really try to make these decisions collaboratively rather than top down. And as we'll get to is to hear each member's perspective. So we really do value that. And some of you may have gone through lean initiatives. Lean really impresses that upon us also, is that all the stakeholders have a vital story or piece to bring, and their perspective is very important. So much so that sometimes people that you don't really know how much they observe really are the key to improving processes. So our values in our department are to be solution-focused, to be collaborative, and to be eliciting perspectives. One of the ways that we like to do that is through a process called appreciative inquiry. In appreciative inquiry, you can look up, there's some easy to understand articles about appreciative inquiry. It really flips the whole concept of problem solving on its end. And instead of saying, how do we fix this problem, we actually ask the question, when we were doing really well at this particular issue, what were the components that allowed this to go well? So what we'll do about once a year or so is to do appreciative inquiry around something. And recently, we as an entire practice and department, one thing that got identified was that there were some communication difficulties between different subsystems of the department. And so we decided to have an appreciative inquiry process during we have a quarterly 1.5-hour team meeting where we talk about the various things that are going on within the practice. And so we decided to lead this appreciative inquiry process, and it went like this. We asked everybody to think of a time when communication was going very, very well inside of, at work. When was communication between the different subsystems going really well? Jot down a few notes about that. And then we had people get into groups of 3 and to then share with each other what they were noticing in those times when communication was going very well. The groups of 3 were an individual from each one of those subsystems. In our practice, that would be the providers was one subsystem, clinical nursing was the other, and then the registration people were the third. And what we did is we gave them instruction about how to listen well to each other, and that the real important job in the next 5 minutes was to listen well for themes that they were hearing from each other, and that we would collect those themes. And that's what you do after that brief period of sharing in those trios. is to collect the themes about when we're doing well with communication, what are the things that are happening to make that happen? And then by then collecting those themes, we then can move into, all right, how do we cultivate these particular pieces even more so? What do we need to be doing to make these particular things happen? So I really suggest the appreciative inquiry process, which really is a solution-focused way to go about that. The third component that Sarah talked about was recognizing knowledge and decision-making. And this is that part about talking to people in the trenches and really fully listening and engaging. In the Lean process, they teach you to do this in a very intentional way, to go into the process and observe and listen and be really attentive and getting people's perspective about how to do things a little bit differently. And then the real question is what can we be doing better? What can I do to help you do your job better? I think that is a key question for leaders all the time, and I ask that almost every day. What can I do to help you do your job better? So the other example is our patient and family advisory group that we started, I believe, about 5 years ago now. We asked some of our patients to be part of a group to help us understand how we could be doing things better in our practice. And we assembled these people, and I was there for the very first meeting. We did our introductions. We let them know what the purpose of all this was. And we asked them to start things out is, help us understand what we can be doing better. We really want to hear your perspective. And the first thing that they all identified, like almost unanimously, was many of them had been patients in our practice for a while. And we are a teaching practice, meaning that we have residents, we have medical students, we have faculty members. There are no providers in our practice that see patients full time, meaning that they're not here every single day. And many of our learners, almost all of our learners, who are the majority of our practitioners, are only with us for 3 years. And a major misunderstanding that we've had for a very long time, it's not uncommon in teaching practices, is why does my physician leave after 3 years? I just got a chance to know them and then they're gone and I really like them. And our patient family advisory group, many members who've been there for 20 years, still did not have a clear understanding that this was a practice in which we train people to be the specialists in family medicine and then they move on. And so we said, well, we asked them, how should we language this differently? What do we need to be teaching people when they come in? What should our practitioners be sharing with the patients so that people really understand this? They actually took our brochure and rewrote our brochure so that people would understand that when they came in better, the ones that chose to read the brochure, and they gave us very concrete suggestions about how soon to inform patients when a resident was leaving. And they also helped us rewrite the letters that our residents send out to patients when they are leaving, thanking them for helping them learn how to be a family physician, for example. So recognizing that they were the experts in how they experience our practice helped us be much more patient-centered for the patients who came after them. The other piece that we have in our practice, we just started this along the solution-focused arena, is we have meetings on Wednesday mornings in our various subsystems, but we all come together on 5th Wednesdays, and we intentionally called this Elizabeth Family Medicine Solutions Meeting, not problem solving. We will put something up there that here's where we are as a practice, here's something we're struggling with, but what we want to walk out of here with is at least a solution to it, or at the very least, a pathway by which we're going to get to the solution. So again, in that session, we are cultivating all of the different ideas from each of the members of the team to understand what the challenges are in the processes. Again, it is more facilitation, and I will also offer, I don't lead that meeting. We have individuals from the various subsystems who stand up there and facilitate that discussion. It is not necessarily the leaders of the practice that do that. Finally, that concept of cohesion between principles and practice. as I thought about this when Sarah and I were talking, it's really all the above. If we are putting into practice those principles which I mentioned above, there really is this sense of cohesion that occurs when we are doing a good job listening, when we have said, here's what our vision is of how we can be patient-centered. We're modeling that, and we are eliciting the different perspectives of everybody as a result of that. I jotted down a couple things, is that if we want our team members and our staff to be patient-centered, we need to be team-centered with the staff. It's a parallel process, so that if we're eliciting their perspectives, if we are making sure that they are getting what they need with respect to how they can do their job, they're much more likely than to do the same with the patients. And thereby the process itself fosters that patient-centered environment. So it really is all the above. And what I want to share is more of some pride in that the more we have done this, the more that we have increased our teammate engagement. So by some of the scores that indicate how well engaged the teammates are, this past year, all of our subsystems were at the highest level of teammate engagement for the entire healthcare system. Our quality measures, while we are a safety net clinic, which is pretty challenging to get some of the quality measures up to speed, we actually lead the entire system in a couple of them, and as a result of that teammate engagement. And then finally, our patient experience or patient satisfaction scores, we're also doing very well in their comparison to some of the other practices who have similar patient populations. And so with that, I will, I don't know if we're ready to say thank you yet, but I know we have some opportunity for some questions.
We do, and thank you so much, Sarah and Dale, for an excellent presentation. Just a quick reminder to all of our participants, if you have questions that you want to direct to the speakers, you can type those questions into the chat box, and we've got plenty of time for some Q&A here. Just to get started, Dale, there's a question that I think is directed to you. You talked about engaging patients as part of a patient family advisory group. How did you get that started? How did you identify which patients to invite? How did you explain to them what their role might be? Can you give us a little bit of the steps you took in the process to make that happen?
So I'm not going to remember all the details, but I'm going to do the best I can. I was part of a team that came up with the idea that we wanted to do this. I should also say that we also have a very active research division within our department, and our research division has done focus groups for some of the research that they've done. So they were experienced at getting patients from our practice identified who could be helpful around asking them questions about a specific issue that had to do with research. A lot of our research is in shared decision making, for example. So I'll start there by saying that it was one of our research associates who was really helpful. But what we did is we actually asked team members to identify patients who they felt would be able to give us a really good objective view of how we are doing with our practice. And we didn't want just patients who really liked us. We also wanted people who were constructive in their criticism of us. Not people who are complainers or whiners, but we wanted people who said, you know, I think when you kind of hear these comments, you know, I think you could do a little bit better at this. Or, you know, when I called, I didn't get a response for 3 days, and that's happened a few times now, and that's really frustrating for me. But not so much from the whining perspective as much as I think I have some ideas about how that could be helpful. So we asked all teammates to identify various patients that they've seen who met those qualifications, and then we called them to see if they would be interested in being part of that, part of the patient family advisory group. We also provide lunch for them, which is a pretty important piece. To do something for them, to thank them for their perspective. And so, so let's say I talked about how we identified people, we called them, got them engaged, and then we brought them together at a time when they mostly could get together. But then we also had facilitation by a physician as well as a nurse, and then one of our research associates who was skilled at doing focus groups were part of the group that got them together. I hope that answers the question.
I think you did an excellent job answering that question. I'm also going to take opportunity here to plug some of our past webinars that have addressed some of the specific steps to take in terms of getting started with patient family advisors if you're creating a patient family advisory council, or if you're incorporating them onto your team. Much of the same information that you just presented to us, Dale, is included in that, along with some job descriptions for some roles that might be a little continuous. I would encourage you to go to the tcpcc.org website, and if you click on the button that says Practice Transformation, we've got a whole bunch of resources, past webinars that address some of these. We certainly know that a patient family advisory counselor group is one of the strategies that a lot of practices use, and we've heard some great experiences and stories about how that has been so key to making some positive changes in the practice, just as you described, Dale. And a couple things, we're going to be offering some additional training and webinars around that in the upcoming months. But then we're also collecting stories from practices. I posted a link to our website. We have a specific web form for those practices that have already done this work and they want to share their strategies and stories and tools and resources for how to make that happen. Not just the patient family advisory councils, but any way in which you're engaging patients and families in this ongoing clinical transformation. So I sent the link to that web form on our website, and we're really trying to create a national map of all the practices that are doing this phenomenal work for lots of different reasons. That, you know, we think a lot of times one practice might identify with another practice that's in their community that's done this, or they might want to find a practice that's kind of like theirs. Maybe they're a small, independent, rural practice, and they're not sure how to make that happen. If they find another practice that's similar to theirs, they might have a better understanding and appreciation for how to get that done with a smaller staff. So lots of different strategies that we want to present and to tell those stories. I think, Dale, both you and Sarah talked about the importance of sharing stories. So we want to hear from the clinicians who've done this work and found such value in it, but also from the patients themselves who've been engaged in this in a way that they haven't done in the past. And these are new roles within healthcare systems and practices. So we want to hear those stories as well. One other quick bit of information to provide to everyone: if you have patients and families that you are engaging as advisors, we're also recruiting them to our PFAC network. That's a network that's everyone's invited to, but it's really there to help support those patients and families in their new roles, and to provide them an opportunity to ask others that are doing this work questions, to get resources, and then we'll be providing them more information about training and upcoming opportunities that they have to engage either as participants in learning more about doing this work, or even as faculty in presenting to others how to engage in this new area of work. So lots of resources available, and we're really hoping that our support and alignment network helps to not only support all this work that's already being done, but that really helps to grow it. So we've got some more questions that have come in, and Dale, there's another question directed at you asking if you could share your colorectal cancer screening outcomes and any other quality measures that you utilize that you think have been particularly impacted by this work that you've been doing in terms of patient and family engagement.
I can't remember the details right now about our colorectal screening, but I think we are above the system goal. I think the goal is somewhere in the 70s to 80% of our patient population have received appropriate screening for the entire organization, and we have exceeded that goal. And so that's one of the things that we've done. The other thing that has been historically powerful was in the realm of collaboration, was working with out of control patients with out of control diabetes. And we, again, I've mentioned that we're a safety net clinic, which means that we have a lot of patients who have a lot of difficulty getting the resources. Just first of all, just the resource to do what to help them with their diabetes in terms of medications, but also just resources in general to be able to, there's food insecurity and housing insecurity and all that. So there's a lot of challenges with that. And we have we've written an article about this some time ago about the impact of a collaborative team approach to impact this, and we were able to show an impact on by looking at A1C scores. And the collaborative team included a pharmacologist, a physician, a mental health specialist, and a social worker, which makes some sense when you are working with a disease that has a lot of social determinants that impact whether or not it's going to do well or not. It is not just the medications alone or what the physician does or even just the shared decision making. It is also about all these other components as well. So that's another piece that we did independently. It is also a goal of the system, and we were able to show an improvement over the previous years that same population had been cared for. We are a safety net clinic, and so we still have a lot of challenges. So meaning that we have a lot of the out of control patients with out of control diabetes. So we are not quite at the system goal, but that's more around our skewed patient population with respect to that.
Fantastic. So Sarah, I want to ask you a question, and then Dale, I think you might be able to follow up on it to talk more specifically about the experiences at Carolina Health System. But so Sarah, when you're starting to talk about this huge culture shift and organizational change, this is something that doesn't happen overnight. So from Planetree's experience, when you start to do this work, especially with the larger health systems, from the very first day that you walk in the door to where these organizations start to really see change happen and become institutionalized, how long does that take? Is it years? Is it months? Is it, what's your experience been at Planetree in terms of really changing the overall structure and the way decisions are made and quality improvement is done across the organization with the patients and families at the center of it?
Well, it certainly doesn't happen overnight, and I know nobody thought that it did. The research shows that culture change takes, on average, about 60 months. Having said that, there's a lot of variability in there, and within that around sort of the size and complexity of the organization. And I think another really important factor to keep in mind is that this is never work that's ultimately completed and behind you. It really is something that needs to be continually nurtured and sort of monitored, because what you don't want is to sort of slide into some complacency. But I think it's very reasonable to expect to see some very positive changes within a shorter time period, and part of that is sort of the sequencing of this work and starting off with a combination of what we would call just do it type initiatives, where you're going to see a fairly big impact in a short period of time because it's the low-hanging fruit, if you will, but taking those on at the same time as you are starting to make some headway on some of those more challenging long-term propositions. But especially for members of the care team, it will be important for them to see some early results to sort of create greater buy-in and enthusiasm and that desire to really be involved in this transformation as it unfolds over time. But if you were to sort of put me on the spot, I would sort of look at that 45 to 60 months time frame for organizational culture change.
That's a significant investment, but as you pointed out, once that overall change has happened, then, and we've heard this from other healthcare organizations, that they couldn't think about doing it any other way. Like, this really has become part and parcel to the way they do business.
Right.
Dale,
That's
what was your
baked in
experience
at that point?
Yeah. Right. Oh, Dale, you
Was
might
there a
be on
question
mute.
for me?
Yeah, we're just at Carolina Health Systems. You said you've been doing this work for 8 to 9 years. From the first day that it was initiated, where did you start to see it? At what point did you really start to see the overall shift across the entire system and how you do care?
So let me just go back and say that our introduction from a systemic change point of view was through the community hospital that we're associated with, which was undergoing the Planetree's with Planetree's consultation, going through their culture shift and change. And I would say that, actually we were lucky in that institution in that the history of that institution was compassionate care, and there were quite a few people that were still left in the system who had been there when there was different ownership, but the highest priority was compassionate care. So I think we started. I really agree with what Sarah just said. There are these very early on wins that don't take a lot of doing, and they don't take a lot of energy, and they don't take a lot of resources, but really cultivating each of the team members' ideas about we could do just this, just a little bit different to make it much more patient-centered. And that really builds on itself. So you begin to see it right away. I mean, once you start doing some of those focus groups or retreats or however you want to do that, you can begin seeing changes within days and weeks. Then they build on themselves. And then that point at which you should say, I don't think we can do this any other way. I would say in our community hospital, it was more about 3 to 4 years, where we would just say, we take a mental snapshot of where we were 4 years ago and where we are now. We can't imagine doing it the way that we did it back at that time.
Yeah, absolutely. I think that those are the stories that we've heard, and as you start to build on those successes and you start to naturally see where you can infuse patients and families in ways that you wouldn't have thought about from day one, even as teachers to faculty, we've seen patients and families engaged in interviewing new clinicians that are coming into practices or in positions of leadership. So lots of very interesting and creative ways that the patients and families have become infused across the organization in ways that they hadn't imagined when they first started down this journey. Dale, another question for you. Do you in your practice utilize health coaches? And if so, in what capacity do you think they're tied to quality measures or quality outcomes?
Excellent question. We do not have health coaches per se. Having said that, we have 2 almost full-time care coordinators is their title, and these are both RN nurses, and they have learned how to do some basic elements of motivational interviewing. And so in essence, what they are doing is health coaching. They're not fully trained as a health coach might be, but they are involved with that. And actually their main purpose is in looking at our patient population, identifying where there are some gaps in their preventive care, but also gaps in their chronic disease management. And in communication with them, mostly by the phone, and what they are involved with is if they haven't had colorectal screening, they make sure that they figure out a way to make sure their goal is patients that have out of control diabetes. I will see the patient and I will send
And Dale, this we were talking about before the presentation started and your relationship with CCNC. How are you engaging, and it might be through that organization, or how are you also helping through your care coordinators to connect patients to other resources in the community? Do you have any kind of key partners that are helping with some of that self-management or ongoing peer support? We talk in our support and alignment network, one of our other partners are YMCA USA, and talking about a lot of the programs that they offer. But certainly we know that patients are mostly managing their chronic conditions when they're not in the practice. So can you speak a little bit to some of the work that you're doing in that area?
Right. It's real similar to what I just mentioned. So our practice has the 2 care coordinators, and then as you mentioned, Amy, CCNC is Community Care of North Carolina, which is managing the Medicaid population of North Carolina. We actually have 2 additional care coordinators for that population also embedded in our practice. And so they do pretty much the same thing. They probably do more of connecting patients with community resources to assist them with their chronic disease management. They do a lot of home visits. They'll meet the patients where they are. They ensure that the patients are getting transportation. And again, a lot of their work is really reducing those barriers to effective health care.
Fantastic. Well, I think we've hit most of the questions. I'm going to put up another quick link to other resources that we have at the PCPCC that will help many of you, I think, as you engage on this journey. Certainly, I would encourage you to also, if you're interested, reach out to our partners at Planetree. We also have partners at the Institute for Patient and Family-Centered Care. And I mentioned the YMCAs. That's another exciting opportunity in terms of developing some key strategies to link with community partners who really do have some excellent evidence-based programs in managing designated populations of patients. So I want to take this opportunity to again thank you, Dale, thank you, Sarah, so much for this presentation. Again, this presentation will, in its full recording, along with the questions and answers, will be up on our website by the end of the day tomorrow, along with a copy of the slides. So please do access that, as well as all of our past webinars. We'll be having and promoting another webinar for the month of July, but we have also a webinar that information is available on our website just next week, talking specifically about how do you engage clinicians in this work. Again, this is not something that most clinicians have talked about in their formal training programs. This is very new work to them in terms of engaging patients and families in quality improvement. So I would encourage you to participate in that as well, and all that information is also available on our website. So thanks again to everyone, and I hope you all have a wonderful afternoon. Bye-bye.